Probably I will tell you the fundamentals, the things that you already know, but saying things in a bit different way may bring chaos at first, but later you may put your things in new order or to get some inspiration when you perform your surgeries in the future. So what are our expectations as surgeons? For sure they are very high. We all would like to have clear cornea with safeguarded endothelium, with using as little ultrasound as possible. We would like to have stable anterior chamber, and we would like to remove the lens dynamically with short surgery time. And we would like to have universal machine to remove the lens, all type of lenses. And to achieve this, we need good technology that gives us Oertli with OS4. We can use free pump system that is based on law of physics, and also easyPhaco technology with EasyTip. And I would like to say a few things about easyPhaco technology. It gives us very nice followability. It's really safe. It means that in a magnetic-like way, it attracts the lens fragments. So there is no turbulence. The lens fragments enters the tip directly. And when we already hold the lens, there's no way to lose it. The holdability is so strong that you can do maneuvers, you can chop very precisely, so you can feel comfortable with this. And with enlarged opening of the tip, we can grab and use ultrasound on bigger surface of the lens. Anyway, the total amount of energy that we use is reduced. And also easyPhaco gives us very nice anterior chamber stability. There is no risk for surge thanks to special construction of the metal tip and also of the sleeve. A few words about my settings that I use. I use only one program for lens removal, and after that IA setting. I used to use peristaltic pump with 45 flow and 450 vacuum, but right now I'm a big fan of Venturi pump with 420 vacuum. The bottle height I adjust to the situation, to the program, to the lens. For sure, the intraocular pressure is not too high. It does not destroy endothelial cells, but good enough to protect from collapsing. I mainly use the incision 2.4 and use phaco-modulation mainly continuous. I used to use pulse and burst. I played with this, I changed all the time. But right now I think that continuous is more comfortable. With very nice working of foot pedal, I can beat my own rhythm of the ultrasound, so it's fully controllable. In phacosurgery, the details are the most important, and I think that hydrodissection is the most important step of the surgery. When I was learning surgery, everyone told me that capsulorhexis is the most difficult one, but I think that precise hydrodissection is even more difficult. Of course, I tried to perform hydrodelineation, particularly in soft cataracts, but hydrodissection precise is very, very important. And exception is, of course, posterior pole cataract. Other detail that I pay attention is how I hold the bevel. I try to use it bevel down and sideways to go into the fragment that I want to catch. We have to remember about that during surgery we use not only jackhammer energy but also cavitation effect. And cavitation effect may be our friend, but sometimes our enemy. It does not mean that I don't use bevel up at all. I just try to reduce it because of the cavitation effect we may destroy endothelial cells. I mainly use phaco chop. I begin, or at least I try to begin with this, but sometimes I finish with freestyle, as you will see later. I perform phaco chop vertically or horizontal one, depending on the lens. But sometimes I need to convert to tilt and tumble, lollipop, or bowl technique. Here is first cataract that I would like to show you. This one is quite hard but brittle. Always I check the sleeve if it's put in right position. The opening needs to be parallel to the opening of the tip. And as I said, I use just one program for pre-phaco. Now you can see I will do pre-phaco. And I try to give bevel down and a little bit sideways. And here I enter the central part of the lens, and I can chop it with my chopper. With very high holdability, I am sure that I will not lose the lens. I work on high occlusion. If we work on high occlusion, it means that we do not let too much BSS entering the eye, so we do not rinse endothelial cells, so the cornea is much better. This movie is from Venturi pump, so you can see how it jumps into the opening, like vacuum cleaner at home, that we use at home. I do like this movement. This also enables fluid to circulate in better way. And with good hydrodissection, the fluid goes under the lens and it just comes into the opening. So part of the lens is already left here, but we still can work very safely because we have very nice anterior chamber stability. But there is one thing one situation that may happen, that anterior chamber collapses. If we perform too long main incision, the sleeve will be squeezed and we will not give possibility to fluid to enter the anterior chamber. So this is the only one situation that we can have collapse of anterior chamber. But as you see, even with the very shallow part of the lens, anterior chamber is still stable, so I can remove it even with bevel down all the time. And as you see, I just move it around so it comes easier. The next one is soft cataract. Here I perform a hydrodissection, precise one, and after that hydrodelineation that gives us the golden sign. Later in a few seconds you will see how I add a little bit more fluid into the central part. Just a second. Okay, now you can see it. Just in case if I will not be able to perform phaco chop, because this one is very soft, so you will see why it's very helpful. And here comes the easyPhaco tip. Yes, the sleeve is too, I corrected this, and the end of the sleeve needs to be a little bit, there should be a distance between the end of the sleeve and the narrowing of the easy tip, so the fluid circulates in better way. And again, I perform pre-phaco. Here, bubbles always come into the anterior chamber, or sometimes. Okay, so pre-phaco, and I try to perform phaco chop, but it's very difficult because it's very soft one. So I go more to the center, and I took up the nucleus, so it was like a lollipop technique. And the rest of the material that is very soft, it just removed very fast in few seconds, as you see. And all the time I hold the bevel down, so it's easier for the lens to enter the opening. So the anterior chamber is still stable, even though not many fragments left. And the last one, this is a mixture of the hard one, or the central part was the hard, and the cortical masses were very soft. I performed here a nice hydrodelineation. I have two rings, golden rings, but for sure hydrodissection is also performed. I check the sleeve, performed again pre-phaco, and with very nice holdability. You will see here I catch the central part. I divide it to two hemispheres, and you can see how it holds very strongly, so I can lift the lens. I do the maneuvers, and easily with chop I divide it to smaller parts. And the second part, it also goes very, very fast with, again, bevel down. Yes, it's going very fast. I don't need to do anything, just to move the foot pedal. And also even the thin part of the cortex also comes, it's like, yeah, very easily. Okay. In PubMed, we may find a lot of articles and citations, pros and cons high fluidics. But I think that the most important part is that we feel safe and comfortable with the machine, with the settings. For young surgeons, I can advise you just to do the things, just to enjoy the surgery instead of feeling fear. And my advice is to trust clinical application engineers. These are the guys that enter your OR and try to change your settings, and you are frightened and no, don't. It was fine, because really they have very, very high knowledge of law of physics, and they really know how it works. Even though we are responsible for the complications, but they are really clever. So to summarize, in my opinion, high vacuum and working on high occlusion gives us faster and safer surgery. So we do not let too much fluid enter in the eye. We reduce the endothelial cell damage. And next day, first post-op day, when patient enters our room for control, we can see clear cornea. Sometimes I laugh that when patient comes next day, I do not even need the slit lamp to check how does it look, because the flesh of the eye microscopically and the smile of the face of the patient, it's like, for sure, it was, the cornea is nice. And here I would like to also thank one person that helped me a lot, Mariusz Jagiełowicz, that is a clinical engineer, application engineer. Thank you very much for your patience, for my questions, and I'm astonished by your knowledge. Thank you very much.